preparatory course, which is cardiology. Why we normally every year, every season, we start with cardiology because it is as per the Cobertris module carries 20% of the total marks in the EDIC 2 exam. So this is the highest marks weightage in terms of the examination. So it is very important that we should be focusing on this part sincerely, dedicatedly. And that's why we always keep cardiology as the module number 1. And this time, due to many people's demand and request, we have kept it free for everyone to join. So many people have joined, and many people, because of their busy schedule, they are about to join in couple of minutes. But we will not be wasting any further time. And to respect the time of everyone, we are starting with the CCS, which is clinical case based scenario. Now, the questions that we shared 2 days before to our registered candidates, that paper contained CCS1, CCS2, and around 20 plus CBS questions specifically from the cardiology domain. Now we have another module or domain, which is cardiothoracic surgery, which would be discussed later on, like in the subsequent domains. But this is specifically related to the cardiology part. Now, the CCS1, the clinical vignette 1, a 55-year-old 82 kilogram weights, 164 centimeter height, male presents to the emergency department with acute onset dyspnea, pleuritic chest pain, and mild hemoptysis. He has a history of recent surgery, that is hip replacement 10 days ago in other hospital, and bizarre type of type 2 diabetes mellitus. On examination in the emergency department, the patient had respiratory rate of 28 per minute. Patient is sinus tachycardic. Blood pressure is 95 by 65 millimeter mercury, and SpO2 on room air is 89%. So this is the first clinical vignette when you will be also appearing in your real EDIC 2 exam. So this will be shown to you in the computer. Now, based on this, you will be also supplemented with some of the clinical findings and investigations. And for this case, this is the ECG and the chest X-ray that is given to you supporting your clinical vignette 1. So I am just zooming it. Those people who have attempted the mock test, so they know about the ECG and X-ray that were like in the Google form. But for the others who have actually joined in this webinar specifically, so this is the ECG, just go through, and this is the chest X-ray. And also adding this, the baseline D dimer is 7.7 milligram per liter. Now, the first question from the examiner in the EDIC 2 and from me also, what is the most likely diagnosis and the next best diagnostic test? Please post your answers in the chat box. I want interactions in the webinar so that everybody will be benefited. It's not the typical one-sided discussion where I will be only talking. I expect and also recommend that you also participate in the discussion. So I'm just trying to, yeah, okay. So there are two answers already popped up. CTPA. I'm just sharing the screen, so you will also be getting all the answers in the chat box because I am only trying to also find out who are like the persons who are answering. I want a strong recommendation from the very first of our course. You have to be vocal. You have to be seen in the discussion. That's the most important point, or I would say the level 1 of any game, that is you have to be seen that yes, you are participating in the discussion. And I recommend that you all start answering, whether it is right or wrong, that is a different thing. But you have to be participating. You have to be participating. Mantra number 1. And I have also posted in our dedicated WhatsApp group. Okay, no worries. Now, what is the most likely diagnosis? Many people have attempted rightly. Most likely diagnosis is pulmonary embolism. Here, Just see the question. Most likely diagnosis. It is not differential diagnosis. So you have to answer only single like answer or single diagnosis. If you are diverting, you are deviating from this question, examiner will be just like no, will be taking you lightly and you will be losing your valuable time. Then next best diagnostic test. Again, though it is again best diagnostic test, but there is one word in front of the best diagnostic test that you all have to be attentive. Next best. It is not the completely, I would say, the best. So the next best test people have answered also in this forum, bedside echocardiography. Bedside echocardiography to assess for right ventricular strain in unstable patient, because this patient is unstable. Everybody agrees with me? And now the next answer you can add upon. The next best test is CTPA, which is everybody has also answered. That is gold standard for diagnosing PE. And if CTPA is contraindicated, you can answer VYQ scan. But these are the answers the examiner is expecting. In our course, we normally recommend and also discuss the structure, the way the answer should be framed. And most of the people who have given us feedback, they actually lack if they don't attempt the domains that we share, the mock exams, and also the debrief. So that's why the answer that I am actually trying to make with the question and the answer try to get the hint. Most likely, next best. So all these are actually the clinical pearls that I want to share with you during the discussion. Now, the next question is, what are the key diagnostic criteria for pulmonary embolism? Can anybody just like summarize in 1 2 3? No detailed discussion, no detailed answer. I will be anyway showing you key diagnostic criteria. Whatever you can just share in the chat box. Yeah, perfect. Don't keep quiet. Yeah. Risk factors. Anyone who wants to add upon? Okay, no worries. Just for the sake of time. First one would be clinical features. Symptoms of deep vein thrombosis, swelling, pain in one leg, elevated D dimer. Though it is not a clinical feature, but yes, it's a lab finding. Imaging findings, CTPA, filling defects in the pulmonary arteries, VYQ scan, if you have not done CTPA because of the obvious reasons, ventilation perfusion mismatch has to be there, and echocardiography, where you will be getting right ventricular dilatation, McConnell signs. Okay, and now ECG changes. Sinus tachycardia, S1Q3 T3, right axis deviation, or right bundle branch block. So these are the key diagnostic criteria for pulmonary embolism. Everybody agrees with me? So the whole idea of like sharing this like this slide with you, always have a structure in your mind. Don't like answer one thing like no the pain in one leg, then sinus tachycardia, then echocardiography finding. So always has to be a broad heading and then under that subheadings. Clinical, lab and imaging, ECG changes. Now, what is the initial management plan for this patient? Okay. First one, definitely patient is having a respiratory rate of 24 or 30, whatever we have mentioned. Saturation is 89%. So oxygenation, we have to keep at least our target SpO2 92 to 92%. Then the most important thing for us at this point of time, thinking about anticoagulation. I am not mentioning the ABC because ABC anyway you will be doing. So I'm just keeping the most important thing out of the clinical picture, that is the oxygenation, then anticoagulation, that would be low molecular weight heparin, unfractionated heparin if there is a renal impairment, then thrombolysis as the patient is hemodynamically unstable. So we'll be considering definitely systemic thrombolysis, and simultaneously we'll be continuing with hemodynamic support, and that is IV fluid for mild hypotension and norepinephrine if still your blood pressure is not picking up. Clear? In the meantime, I'm just checking if somebody has added anything in the chat box. Okay. Which one is more preferred, low molecular weight heparin or unfractionated heparin? All the guidelines right now, they recommend low molecular weight heparin because of the yes, people are adding. So because of there is no major difference between the low molecular weight heparin and the unfractionated heparin. Rather, low molecular weight heparin, the bioavailability is good and the dosing is also very easy to remember. In the emergency, you can start immediately. And also the comparison of the systematic review meta-analysis that also support low molecular weight heparin. But yes, in case of there is renal impairment, definitely. Okay. Perfect. So everybody is uh, correct in this question also. Very good. Now, what severity scoring systems can be used to risk stratify in PE? Anybody who wants to share? Dr. Milin, hemodynamic support, you can start from the very beginning also. I just tried to highlight the most important thing, that is thrombolysis, anticoagulation, that part. Like you can always start with oxygen support, hemodynamic support, and then anticoagulation and systemic thrombolysis. Yeah, perfect. So many people are attempting. That is a very good sign. PESI score 100% you have to remember pulmonary embolism severity index PESI for mortality risk assessment. Then there is another scoring which is simplified PESI, which is SPESI, focuses on shock and RV dysfunction and echocardiography indicators in the form of right ventricular dysfunction, RV by LV ratio more than 1. Clear? So these are the basic severity scoring system that you can do at the bedside, which will be stratified the risk in PE. For all of you who have less idea about what is PESI scoring and simplified PESI scoring, so PESI scoring is having age, male sex, cancer, heart failure, chronic pulmonary disease, pulse more than 110, systolic blood pressure less than 100, respiratory rate more than 30, temperature less than 30, altered mental status, arterial oxyhemoglobin saturation less than 90%. Just see 60 points would be given for the altered mental status here. And sorry. And then 30 points for cancer and systolic blood pressure. So these are the two major the parameters that would be getting high scoring. Now, if PESI score, if you are adding up everything, less than equal to 65, class 1, more than 125 is class 5, which is the highest risk. Now, they have again, because of all this variation in the numbers and so many parameters, they have made it to simplified PESI. And simplified PESI, the age, cancer, heart failure, chronic pulmonary disease, pulse more than 110, and systolic blood pressure less than 100. So these are the things that have been mentioned along with the SpO2, 1 point. So these are all 1 point. And age, 1 point if your age is more than 80. Now, so that also, if it is 0, 1%, more than equal to 1, 10.9%. So it would be very highly, if you would say that if you are not getting, so definitely the simplified PESI, the mortality rate would be 30-day mortality rate would be definitely less. Now, question number 5 in the first clinical vignette, how do we define hemodynamic instability in acute high risk pulmonary embolism? First one, cardiac arrest. Second one, obstructive shock. If your systolic blood pressure is less than 90 millimeter mercury, or vasopressors are required to achieve systolic blood pressure of 90 millimeter despite adequate fluid resuscitation, and you are also getting evidence of end organ perfusion. Now, if after the fluid also, and you are not having any new onset arrhythmia, hypovolemia, or sepsis, still you are getting persistent hypotension, that is systolic blood pressure less than 90, or systolic blood pressure decrease, that is 40 millimeter mercury, that lasts longer than 15 minutes. So these are the three types, or I would say the hemodynamic instability category that would be definitely you have to consider in acute high risk pulmonary embolism. Now, again, this is one, you can see the pyramid, low risk, where you are getting the simplified PACE score of 0, not getting any RV strain, normal cardiac biomarkers, and patient can be having no symptoms at all, and the pulmonary embolism is detected incidentally. So that is low risk pulmonary embolism. Now coming little bit up, intermittent intermediate low risk where normal blood pressure with either there would be evidence of right ventricular strain on the imaging or elevated cardiac biomarkers, or neither but PACE score more than equal to 3 or simplified PACE score more than 0. So just remember that there is something called as low risk, intermediate low risk, intermediate high risk, and then high risk. In the high risk, as I have already told you, cardiac arrest, cardiogenic shock, and paradoxical bradycardia requiring vasopressor therapy. So sometimes it's not always the tachycardia, but also you will be getting the bradycardia just maybe before the cardiac arrest. So that can be told as or mentioned as paradoxical bradycardia, and hypotension and acute respiratory failure. So this is something called for the risk prediction. Yeah, perfect. Everybody has mentioned again correctly. Yes, there are like other scores also, well score, Padau score that you can mention, but yes, PACE score, simplified PACE score, and echocardiographic criteria are currently being used as like the risk prediction as well as the categorizing the severity of the pulmonary embolism. Now, just I want to highlight. We all know about S1Q3 T3 pattern. Do you know this is also having a name, McGinn White sign? Because these are the two scientists, they have first discovered this S1Q3 T3 pattern. So that's why the name is also having the S1Q3 T3 pattern, McGinn White sign. You can remember this, somebody can ask it. Now, McGinn and White first described the S1Q3 T3 pattern with the subsequent voltage criteria in acute core pulmonal due to pulmonary embolism, that is S wave in lead 1, U wave in lead 3 with an amplitude of more than 0.15 millivolt, and inversion of the T wave in lead 3. So that's why the name is McGinn White sign or S1Q3T3. Don't be misguided that S1Q3T3 pattern is only for the pulmonary embolism. There would be many other cases where you can get the S1Q3T3, but there are certain clinical significances associated with S1Q3T3 pattern regarding pulmonary embolism. What are they? It is consistent with pulmonary embolism. You will be getting it if it is severe pulmonary embolism. It is a fairly well known as an indication of like the acute pulmonary embolism. Highly suspicious for acute pulmonary embolism. More common with massive pulmonary embolism than with smaller pulmonary embolism. Prompt clinicians to consider pulmonary embolism and lead to earlier diagnosis. And it is an indicator for right heart strain and acute coronary, the cardiogenic pulmonary edema. Now, it is a suggestive for the right ventricular strain, indirect marker for risk stratification in a case of the acute pulmonary embolism, and this is also evaluated as the useful for the ECG in predicting RV dysfunction and outcome, and it's all related to the severity and higher mortality. So this is the most important thing that you have to remember if you are getting S1Q3 T3 pattern in ECG. Now, related to the chest X-ray, few things that you should remember. A chest X-ray can appear unremarkable in a patient with acute pulmonary embolism. About 12% of the chest X-rays in patients with pulmonary embolism appear normal, but if the chest X-rays are not sensitive or specific for pulmonary embolism, but they can help establish other diagnosis like pneumonia, pleural effusion, pneumothorax, or anything like that. There are some signs that appear on the chest X-ray: Hampton's hump, watermark sign, Westermark sign, Flessner sign, Palas sign, elevated diaphragm. I'm not going into detail, but yes, these are some of the pictures that you can remember: Hampton's hump, Westermark sign, pleural effusion, Palas sign. So these are the some of the nomenclatures that have been like to given to the findings in the chest X-ray. Now, D-dimer is also having some clinical significance related to the pulmonary embolism. D-dimer level above 1.96 milligram per liter, which is 4 times the normal level, indicate a significant risk of pulmonary embolism. D-dimer level above 6.6 milligram per liter may indicate massive pulmonary embolism. Now, there have been literature, they have actually correlated D-dimer level with the clinical pre-test probability. If you are getting D-dimer level below 1000 nanogram per ml, that can rule out pulmonary embolism. If you are also having low CPTP, that is clinical pre-test probability, and less than 500 nanogram per ml can rule out pulmonary embolism in patients with a moderate CPTP. So this is something we would need to remember or at least have an idea. Now, D-dimer and simplified Geneva score. So if you are actually combining D-dimer test with SGH, which is simplified Geneva score pre-test, can improve the accuracy of the pulmonary embolism diagnosis. Patients with SGH score of at least 3 have a D-dimer cutoff point of 2.2 milligram per liter for pulmonary embolism risk. So this is something you need to remember. And finally, D-dimer and CTPA. D-dimer levels are significantly higher in patients with pulmonary embolism who test positive on CTPA. That means if you are getting the CTPA to be positive, so D-dimer level in those patients are significantly higher compared to the other patients where the CTPA is negative, but you are still having suspicion for pulmonary embolism. Clear? Now, these are some other scores that we have already seen from the chat box. Well scores, revised Geneva score, not going into detail, but in the examination, they may ask you the names and some are other clinical probability, low, intermediate, high, clinical probability, 2 levels, pulmonary embolism, unlikely, pulmonary embolism, likely. Okay, so these are the things that we have read in our training period. I am not going into detail, but yes, they are very important sometimes in the clinical examination. Now, let's come to the Vignette 2. What has happened to this patient? Now, the patient develops worsening hypotension despite fluid resuscitation and norepinephrine. Look, the answers that we have actually mentioned in the clinical Vignette 1 questions, now it is coming in the Vignette 2. So you will definitely get to know that you have actually answered correctly in the clinical Vignette 1. So we have mentioned about fluid resuscitation norepinephrine. It is in the clinical Vignette 2. This patient was put on the right jugular vein central venous catheter and right radial artery line given worsening hypotension. Noradrenaline which was started, that was increased to 15 mics per minute and titrated to achieve a map of 65 mm mercury. Initial ABG was drawn. The pH was 7.10, PO2 60, PCO2 48, bicarbonate 14, base excess -10, and lactate of 10. You got the BNP report, which is above 10,000 picogram per ml. Now, he was intubated, placed on mechanical ventilator for persistent dyspnea, despite you have initially tried with NIV as well. Now, this is the bedside echo finding that you have again answered in the clinical Vignette 1. So again, very crisp. If you are actually answering correctly, you will be getting all those answers as the clinical Vignette points subsequently. So this is the echo finding the examiner is showing to you in the exam. Now, on ventilator, this patient's BP, despite high noradrenaline, remains low at 85/40. SpO2 is between 90 to 92% with FiO2 1, and he is now more tachycardic at 130 beats per minute. On clinical examination and bedside lung ultrasound, you have excluded pneumothorax because you have put the central line. So it could be also contributing to the persistent hypotension. Now, urgent CTPA done because you are so sure that this patient needs systemic thrombolysis and also further management, counseling to the family. So you needed urgent CTPA, which was done despite the patient is hemodynamically unstable. That revealed massive PE with evidence of RV dysfunction. Yeah, perfect. Yeah, somebody is also mentioning. Good. So this is the CTPA finding. So also in the CBS, you will get this type of CT finding. So it is not only that I am talking about CCS. In CBS, which is computer-based system examination, you will be getting typical CTPA finding for pulmonary embolism with 2 lines in the clinical vignette. Clear? Now, his blood investigation showed normal WBC, but SGOT, SGPT is raised now 650 and 450. Serum creatinine is raised to 2.16 milligram per deciliter with urea of 96 milligram per deciliter. You have started thrombolysis injection altiplase 100 milligram over 2-hour infusion. There was progressive decrease in the urine output despite you have started on infusion furosemide low dose with your cardiology consultation. Your BP is low, but you thought that maybe this will be acting upon. Now the chest x-ray showed bilateral infiltrates consistent with pulmonary edema. You have simultaneously at this point of time taken nephrology consultation to think about initiate RRT, but suddenly his heart rate was 150 to 160 per minute, irregular, narrow complex, and blood pressure was 65/40 millimeter mercury. You immediately stepped up the vasopressors to vasopressin and adrenaline. But everything we are doing for this patient, but the patient did not improve. Rather, 5 minutes later, BP was not recordable and PEA noted, that is pulseless electrical activity. You started CPR resuscitation as per the SLS protocol. You achieved ROSC also after 10 minutes. So a lot of events happened in the clinical vignette too. So you have to go through systematically in the exam. Don't be biased or directed towards a particular thought process. Now, what role does echocardiography have in the workup for diagnosing PE? This is something very straightforward question. You sometimes will be getting a very, I would say, clean questions where you can score 100 out of 100 percentage. So when you will be asked about echocardiography, so you can answer diagnostic modality. We have already discussed rapid bedside assessment in a hemodynamically unstable patient where CTPA cannot be done. Now, simultaneously, this echo can also help you to diagnose coexisting other cardiac abnormalities in the form of LV dysfunction, valvular abnormalities such as TR, pulmonary pressure, and volume status of this patient. Clear? Now, what does echocardiography have in the workup for diagnosing PE? So again, the thing that would be added to it, workup, when I am talking about workup along with diagnostic modality and exclusion of other cardiac abnormality, it will also help us to decide on the management plan, like existence of RV dysfunction on echo. If you are unable to do CTPA to confirm your diagnosis, but the patient is sinking and there is strong risk factors, risk prediction scores are very high, you can think about going for thrombolysis straightforward without doing the CTPA. Clear? Now, what are the features on the 2D echo to suggest diagnosis of PE, pulmonary embolism? So there are multiple things. I am just highlighting for your revision sake. Decreased RV regional and longitudinal function, increase in the RV chamber size, TR, abnormal septal wall motion that would be indicating RV pressure overload, McEnroe sign, which everybody knows, where right ventricle mid free wall becomes dyskinetic and there would be sparing of the apex and the base. Sometimes you can get mobile thrombus located within the right heart cavity associated with high mortality. If you are getting that in the echo, mobile thrombus, that would be definitely giving you a very, I would say, poor prognosis for this patient. Distended non-collapsible inferior vena cava, definitely this patient is having obstructive shock. And 60/60 sign, this may be asked in the CBS as well. So what is 60/60 sign? Can anybody just post in the chat box before I will be showing you what is 60/60 sign? The answer is written there, but quickly, if you can just post in the chat box. You are getting simultaneously two things. Your right ventricular outflow tract acceleration time is less than 60 millisecond with a mid systolic notch, and you are also simultaneously getting PASP, pulmonary artery systolic pressure less than 60 millimeter, which is estimated from the TR jet velocity. That is tricrospid regurgitant jet velocity. Just for like the people who have less knowledge about 60 by 60 sign. So this is 60 by 60 sign. The first, you can see the left part, the right part. Now first, let's talk about the left part. Tricuspid gradient, you are getting it. Now from that, plus right atrial pressure you are getting from the IVC assessment. Now, this would be added together. If you are getting less than 60 millimeter mercury, you are getting the clue towards acute pulmonary embolism. Now, on the right side, pulmonary acceleration time, which is you can get it from the pulmonary valve, that would be less than 60 millisecond. That would be again suggest acute pulmonary embolism. So this is 60. Again, this is 60. Less than 60, less than 60. So sometimes it can be asked also. Now, question number 2.3. What are the immediate steps in managing refractory cardiogenic shock? Now, this patient is going into a refractory cardiogenic shock. You have started on everything. You have secured the airway, but this patient's BP is not improving. So first one, vasopressors, inotropes. Inotropes you are adding now. You have already started on norepinephrine. Maximum dose, vasopressin, then adrenaline. So maybe you have to add on an inotrope despite the blood pressure is low. But yes, dobutamine sometimes will be improving the cardiac contractility and cardiac output. Echocardiography you are again doing whether you are also dealing with cardiac tamponade or severe right ventricular dysfunction. And most important thing here, the examiner is actually going towards MCAD, mechanical circulatory assist device or mechanical circulatory support. So you have to at this point of time think about IABP, VA ECMO, or like you have to add on the both the two things for persistent shock. Optimize the preload and afterload. You have to avoid excessive fluid resuscitation. Maybe you are going in the wrong path of your Frank Sterling curve at this point of time. If it is like that, you are actually flooding the lungs. Administer small amount of diuretics if volume overload is suspected, and early multidisciplinary consultation. Engage the cardiology, critical care, and ECMO teams for advanced decision making. So these are the immediate steps in managing refractory cardiogenic shock. Now, when should extracorporeal CPR be initiated? As the patient has gone into the cardiac arrest and you have revived and now the patient is having refractory cardiogenic shock, definitely there would be a question on extracorporeal CPR. So the indications are witnessed cardiac arrest with a reversible cause, refractory cardiac arrest despite 10 minutes of high quality CPR, and absence of significant comorbidities or irreversible conditions like severe neurologic injury. If you are getting a fresh case where there is no neurologic injury, no previous comorbidity, which would be very severely obstructing your the management plan for future, and there would be you are going beyond all your the expectations as well as management protocol. So definitely you should consider extracorporeal CPR. What are the complications of VA ECMO to monitor? If you are putting the patient on VA ECMO, what are the complications that you have to think about? Bleeding from cannulation site due to anticoagulation, limb ischemia caused by femoral artery cannulation, thromboembolism, risk from clot formation in the ECMO circuit, hemolysis due to mechanical shear stress that is happening in the ECMO circuit, and oxygenator failure. So that's why you have to require timely replace the oxygenator. So these are some or other complications of VA ECMO. And what are the major trials on VA ECMO as eCPR? So now the examiner wants to know how confident you are having the evidence or literature on different recent mechanical circulatory assist devices and eCPR. So there are the two trials, arrest trial, tier 2 trial. I'm just mentioning the few salient points about arrest trial. This is a phase 2 open label RCT, and the population that was included patients with out of hospital cardiac arrest presenting with VA for pulseless VT unresponsive to the standard ACLS measures. they have intervened with eCPR using VA ECMO versus the standard ACLS that we normally do. And the finding was this trial demonstrated improved survival to hospital discharge with favorable neurologic outcome in the eCPR group compared to the standard ACLS group. Definitely, this was a positive trial. Now, CHEER trial that was published in 2015, single center prospective observational study, patients with refractory in hospital and out of hospital cardiac arrest. Now, what they did, a protocol combining mechanical chest compression, hypothermia, ECMO, and early reperfusion, like thrombolysis, stenting. So, whatever was the problem, they were trying to have the reperfusion. So, they have added everything. So, that's why the terminology is CHEER, chest compression, ECMO, and early reperfusion. And the finding again was a positive inclination. That is, the study reported 54% survival rate to hospital discharge with good neurologic function among patients treated with CHEER protocol. Clear? Now, there was another study, that is Prague OHCA study, that is eCPR for refractory out of hospital cardiac arrest, where it is again a RCT, multicentral. Patients with refractory out of hospital cardiac arrest of presumed cardiac origin, and they have intervened with eCPR using VA ECMO combined with invasive assessment and treatment versus the standard ACLS. This trial also found a higher rate of survival with good neurologic outcome at 180 days in the eCPR group compared to the standard treatment group. So three trials till now, they are all positive towards like the eCPR. And then one trial still ongoing, that is Inception's trial. Then that is also a multi-center randomized controlled trial, patients with refractory OSCA. They have compared between eCPR using VA ECMO versus a conventional resuscitation strategy. And the objective is to assess whether eCPR improves survival with favorable neurologic outcome. So this is something which we will be again highlighting the role of eCPR. Now coming to Vignette 3. Patient remains hemodynamically unstable on VA ECMO, CRRT, high vasopressor, ventilatory support. Discussions with the multidisciplinary team recommend escalating to additional mechanical support. So you have already added upon like many things, and you have taken the multidisciplinary team decision. Now, what are the indications for mechanical circulatory assist device, MCAD? So one, refractory cardiogenic shock, which is right now our patient is having, unresponsive to the medical therapy. Bridge to recovery, maybe patients with post myocarditis and acute myocardial infarction. If we are supporting for some time, then the patient are supposed to recover. So that is bridge to recovery. Third one is bridge to the decision, where actually we are thinking about, we are contemplating upon the definitive management in terms of the heart transplant. So we need some time. It's not like quickly we will be taking the decision and shifting the patient for OR. We have to prepare the patient for heart transplantation. So that is bridge to the decision, and then finally bridge to transplantation in case of end stage heart failure. So these are the four indications for mechanical circulatory assist devices. Now, there would be another question the examiner may ask in the era where the cardiac critical care is definitely every time, every month, every year is going in the up direction. Classify mechanical circulatory assist devices, MCAD. Can anybody just highlight what is the classification of MCAD at this point of time, just to check your GCS whether you are all with me or not? Anyone? Post in the chat box. How will you classify mechanical circulatory assist device? Those people who have appeared the test. Yeah. Okay. 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 Good try. Yeah. Perfect. So you all are actually having some idea. But when the examination question is all about classification of mechanical circulatory assist device, so you should again have a structure in your mind. How will you actually answer? It should not be random. LVAD. Somebody will be talking about Impella. Somebody will be talking about maybe heart transplantation. No, it should not be like that. So I am just giving you a clue, one like no systematic approach or like a template of answering. So it is classified on various factors, including duration of support, specific cardiac chambers they assist, and their method of implantation. How do you like this approach? Now we'll be again dissecting further. Based on the duration of support, it can be short-term device, long-term device. In the short-term device, again, that means it's a temporary support. Long-term device, extended support. The meaning is very clear. Temporary support is used for hours to weeks in acute settings. And the long-term device, that is extended support, is used for months to years, often as bridge to heart transplantation and those patients who are not eligible for transplantation. Now, what are the short-term devices we are having? IABP, first one, Impella device, and ECMO. These are the short-term devices. Now, for the long-term devices, you all have answered correctly. That is LVAD, left ventricular assist device. HeartMate 3 supports the left ventricle, and total artificial heart, that is TAH, replaces both ventricles in end-stage biventricular heart failure. Clear? Now, the next way of classifying is chamber specificity. Left ventricular assist device supports the left ventricle, which pumps the oxygenated blood to the body. Right ventricular assist device that supports the RV, which pumps the deoxygenated blood to the lungs. Biventricular assist device support both ventricles when you are having biventricular heart failure. Clear? Very easy to remember. Now, method of implantation, which is the third point of classifying the MCAD. Again, that would be percutaneous device, surgically implanted device. Percutaneous device, it would be Impella, inserted through a skin incision using catheter based technique, often via the femoral artery. That is minimally invasive. Now, surgically implanted device is that requires open surgical procedures for the placement and are typically used for long term support, like HeartMate 3 LVAD. This is a durable surgical implanted device for long term circulatory support. Clear? So this is the way of, like, if you are getting the question like how to classify MCAD, so you should remember this. Now coming to the again one particular the MCAD, that is the Impella. What is the role of Impella in cardiogenic shock and the types? Impella is something which would be providing temporary ILV support by unloading the LV, and it improves coronary perfusion and as a result reduces the myocardial oxygen demand. So this is the main function of Impella. And what are the types of Impella, as the question is saying? Impella CP, which is for cardiogenic shock. Impella 5.0, which is like providing higher flow rate in case you are not getting the typical flow or cardiac output in severe cardiogenic shock, and Impella RP, which is for the right ventricular function. So this is something, as it is coming up in European cardiac ICUs, they are using it very frequently. So the question can come on the third or fourth clinical vignettes for the cardiogenic shock. Now, what is the key difference between LVAD and VA ECMO? Because people are also using VA ECMO and also going for LVAD. Now, the basic difference, LVAD is the left heart failure, continuous flow device used for chronic or advanced heart failure, while VA ECMO is short-term cardiac as well as respiratory support. And this is used in the acute critical conditions requiring both oxygenation and circulatory support, that we all understand. Now, what are the complications associated with MCAD? That is the mechanical circulatory assist device. One is infection at the drive line or device site, thrombosis or stroke if there would be some or other blood flow disturbances that would lead to clot formation, and that can again result in massive thrombosis or stroke. And finally, every device is having the chance of malfunction or failure. So mechanical issues requiring urgent attention. Now, coming to the vignette 4, the patient, you have put the patient on mechanical circulatory assist device. Patient stabilizes on mechanical circulatory assist device, but remains dependent on the LVAD. So what you will be doing? You will be listing this patient for heart transplantation. Family counseling is required for the prognosis, donor matching, and post-transplant care. So how do you counsel the family about heart transplantation? So just think about, we started from a typical acute pulmonary embolism, again going into the management part, treatment part, then cardiogenic shock part, then patient had cardiac arrest, eCPR, then you have started on MCAD, then still the patient is not improving, you are thinking about heart transplantation, then the communication part. So how a typical cardiology case has unfolded. So you have to counsel the family about the need for the transplantation, donor matching process also, and the surgical risk associated with this type of major procedure. Now, what are the key criteria for donor recipient matching? One or two important things, very recent things that I will be sharing in this one. One is blood group compatibility, size matching, infection status. If the patient is having any donor infection, definitely that would be having a strong contraindication for like going for the heart transplantation. Now, just to check your IQ level, what is the size matching based on the body surface area to prevent size mismatch? Why it is important? Any smart answers from the group? And what is the size matching? What will you match in the donor and recipient? Anyone? We are coming to almost conclusion of the first CCS. Yeah, size of the heart, height, same stroke volume and fitting in the chest, cardiac index. Okay, very innovative thought process. Age, okay, body surface area, very good attempts. Yeah, definitely you have all attempted well. Outer area, okay. Okay, so I will be just discussing this part. So the importance of size matching is to ensure that the donor heart providing adequate cardiac output and avoids complications post-transplant. So you are going for some procedure which is very risky and advanced, but you don't know if you are actually taking the heart from the donor and putting it in the recipient, this will be functioning well or not. This will be actually compensating or like require like fulfilling the cardiac output demand of the recipient. So that is the most important ideology or the indication that has to be dealt with, satisfied before going for this type of procedure. Traditional approach, donor weight has to be minimum 70% of the recipient weight to avoid undersizing. Clear? This is the traditional approach, but there are some advanced metrics that have been actually developed in recent years. One is predicted heart mass. How will you predict the heart mass? Considering the weight, height, sex, and age for precise heart size estimation, and body surface area, commonly used for the size matching. And there are certain additional factors also. Pulmonary hypertension, you have to carefully match to prevent right ventricular failure, and BMI and recipient specific hemodynamics are critical. Now, what are the major post-transplant complications to discuss at this point of time? One is acute rejection, most likely within first 3 months. Second one is opportunistic infection due to you will be starting immunosuppressive therapy, so that there can be a opportunistic infection, and long-term complications like chronic allograft vasculopathy. There would be maybe the grafts having like some or other inflammations and occlusion that would be having the vasculopathy that would be leading to the graft failure. So these are the major post-transplant complications to discuss. Now, what is the role of ICU team in the heart transplantation care? One is immediate post-operative care. Once the patient is shifted from the OR to the ICU, you have to monitor the hemodynamics, initiate immunosuppressive therapy, watch for the rejections due to the immunosuppressive therapy, vigilantly watch for the signs of infection or rejection. And you have to collaborate with surgeon, cardiologist, intensivist, and other specialists for comprehensive care. So in the last slide, I have actually started with pulmonary embolism. went into cardiogenic shock, cardiac arrest, ECPR, ECMO, mechanical circulatory assist device, heart transplantation, and counseling. So just before going into the CCS2, what is your feedback? If you are getting this type of case in your examination, upcoming exam, how confident right now you are to handle that type of CCS and answer confidently? Did you find it very difficult? Did you find it informative and also very appropriate if you are actually going for a like a very international exam like EDIC 2 standard? Okay, perfect. Because we need to get the feedback from you to tailor made our discussions as well as if you are going above all of your heads, that is very we can say advanced and it is not appropriate. So definitely we'll try to reduce the level, but we are making you very confident in your exams, and you should be going all out for your international edict 2 exam. It's not a like no very simple exam, and the examiners are actually becoming smarter and smarter every time. So they are coming up with a little bit of advanced CCS. It is not the previously typical MI case and what is the management, what is MI, what are the types of MI. No, they are asking you about the recent developments that has happened in the cardiology, and when it is having 20% of the total marks, definitely if you are clicking on the first part which is cardiology, it will be having a lot of impact on your final marks. Okay, perfect, thank you. Now let's go to the CCS2, which will not be so complicated as the CCS1, but again it has some or other like no spices. 52-year-old male admitted to the ER with a 3-hour history of chest pain and shortness of breath. He's a type 2 diabetic and hypertensive on regular treatment. His GCS is okay. Vitals in the EDR, temperature 36 degree, heart rate is 145, sinus tachycardic. BP is low, 80 by 50. Peripheral capillary refill is only 5 seconds, which is not bad, but yes, contemplating his situation, I will be little bit of confused like whether this capillary refill time is actually helping me to perfuse my end organs. Respiratory rate 35 breaths per minute, SpO2 91% on 10 liters of oxygen via face mask. You auscultated the chest, which revealed fine crackles bilaterally. ECG and chest X-ray, which were done in the emergency department, and you are getting the ECG like this and the X-ray like this. I'm just zooming it for all of you to see first the ECG. Focus on the ECG part first, and then the X-ray part. X-ray part is visible. Okay. So now, what is your provisional diagnosis? Somebody has raised hand. Please post in the chat box because I am actually sharing the screen, so I will not be able to. You can post the query. Okay. Everybody has to post at least the first diagnosis, because on that basis only the next clinical vignettes and the question will unfold. So if you are actually deviating from the right diagnosis, the examiner in worst case, I am again highlighting, in worst case will not show you the clinical vignettes, the clinical vignette 2, clinical vignette 3, something like that. Perfect. So everybody, they all are smart people in this group only. I am very happy. Okay. STEMI, anterior wall MI, cardiogenic shock, complicated with acute cardiogenic pulmonary edema. Very nice. Okay. What are the diagnostic criteria for AMI? Simple question. Because I have made little bit simple version in the CCS2. Anybody who wants to share? Diagnostic criteria, clinical criteria, ECG criteria, cardiac biomarkers. If somebody is answering in this structured manner, though he or she is not elaborating all the points, but he or she will be getting marks. So always remember to have a structure rather than giving chest pain, radiating to the back, to the left hand, ECG criteria, ST elevation. So just have a structure, mention that, you will be getting at least 60% marks. Okay. Now, what is the definition of STEMI? New ST elevation at the J point in two contiguous leads of more than 0.1 millivolt in all leads other than lead V2 and V3. For lead V2 and V3, for main more than 40 years, more than equal to 0.2 millivolt, more than equal to 0.25 in main less than 40 years, or more than equal to 0.15 in women. You will not be getting always ST elevation, but some other conditions which are also treated as STEMI, they are new or presumed new LBBB, left bundle branch block. You may get isolated posterior MI, which is almost equivalent to the STEMI, that is new ST elevation. So these are also the I can say the classification 1, classification 2, 3, and presence of reciprocal ST depression helps confirm the diagnosis. So if you are getting ST elevation, there would be also reciprocal ST depression. So if you are getting that, that would be confirming your diagnosis. Clear? Now, what are the criteria for acute myocardial infarction? Again, I have already discussed new ischemic changes, clinical evidence I have already mentioned, increase in the cardiac enzymes in the form of troponins, and one of the following, that is new ischemic ECG changes, development of pathological QFs, in the echo you are getting typical imaging evidence, and in angiography if you are doing, then you are getting coronary thrombus. So this is the criteria for acute myocardial infarction, whether it is type 1, type 2 or type 3. We will be again going for the what are the types of MI. Now, before that, I want to highlight upon something. You all should be clear on the coronary circulation to the conduction system. RCA, LAD, LCX. These are the three major coronary circulation that we need to be very thorough. Now RCA is supplying to SA node, AV node, bundle of His and posterior fascicle of the left bundle branch block. LAD is for AV node also, bundle of His, right bundle branch block and anterior fascicle of the left bundle, and left circumflex posterior fascicle of left bundle branch. Now, if you are getting the leads 1 AVL V5 V6, that is actually lateral wall and supplied by left circumflex. 2 3 AVF inferior wall right coronary. V1 V2 is actually anatomical area is septum supplied by left anterior descending, and V3 V4 is anterior wall which is supplied by left anterior descending artery. So if you are getting V1, V2, V3, V4, it is anteroseptal. Clear? If it is inferoseptal, 2, 3 AVA, V1, V2. Anterolateral, you are actually getting 1 AVL, V3, V4, V5, V6. This is anterolateral. Anteroseptal is V1 to V4. Clear? And in the picture straight on the ECG, you can see here 2, 3 AVF, it is RCA. That is inferior wall, and all these things as per like the LAD is almost, you can see the maximum here. LAD left anterior, so V1 to V4 you are getting all the things here. LAD you can see here in the coronary circulation classification and also on the ECG, how like you have to be damn on the ECG on the basis of the coronary circulation. Okay, now how will you classify AMI? What are the types of AMI or MI? Anybody? Anyone who wants to answer this question? What are the classification of MI? Okay, type 1 is primary ischemic, which we all get in our CCU. Type 2 is increased oxygen demand or decreased supply. Type 3 is unexpected cardiac death with symptoms of ischemia. Type 4 is MI associated with PCI or stent thrombosis, post thrombosis like the stent thrombosis, which are the complications. And type 5 is MI associated with cardiac surgery. Clear? Now, I want to highlight upon type 2 MI. Type 2 MI is more of like the supply demand mismatch. So the context would be, it is not primarily related to the cardiac etiology, rather secondary to another illness or process. And the main reason leading to clinical presentation is oxygen supply and demand imbalance. And that can be resulting in fixed coronary atherosclerosis, coronary spasm, coronary embolism, dissection, sustained tachyarrhythmia, severe hypertension, severe bradyarrhythmia, respiratory failure, severe anemia, hypotension, or shock. Clear? Now, how will you manage this case? Again, ABC, specific management for ACS, which is primary PCI, and management of the complications. Always divide in this manner category. First is the resuscitation part or initial management part. Second one is the definitive management part. Third one is the management of complications. What you actually do, there will be some other complications. So that also comes in the typical management. Clear? Now, thrombolytic therapy in STEMI is within 12 hours of the onset of symptoms, for whom reperfusion with primary PCI cannot be performed within the recommended time. So if you are actually unable to do the primary PCI within the first 12 hours, but there is a definitive STEMI, so you can go for thrombolytic therapy. Clear? Now, what investigation will you do at this point of time before going for primary PCI? So definitely cardiac biomarkers, echo, FBG, chest X-ray, urea creatinine, platelet, PTINR, because you are going for using heparin during your primary PCI. And you need to know about the renal status because you are using contrast during the angiography. What are the complications of AMI or acute coronary syndrome, acute MI or ACS? Again, you have to divide in this format. Ischemic, angina, reinfarction, infarct will be expanded further. Second complication would be electrical complication in the form of arrhythmias, heart block. Third one would be mechanical in the form of cardiac arrest, thrombotic and embolic complications, heart failure, cardiogenic shock, mitral valve dysfunction, aneurysm rupture, cardiac rupture in the form of septal and free wall, RV failure, LVOT obstruction. So all these are mechanical complications following your myocardial infarction. Now, there would be some delayed complication as well in the form of pericarditis, Dressler syndrome. Clear? Okay. Now, the patient underwent primary PCI, as you have already suggested and discussed. Still, he is in persistent shock. What are the possible causes at this point of time? Can anybody suggest? Yeah. Anyone? Why the patient is still is in persistent shock? There would be a situation which is known as acute systolic failure or myocardial stunning, reperfusion injury with arrhythmias, patient is bleeding somewhere, patient is resulted in cardiac tamponade following this angiography and angioplasty, septic shock, hypovolemia. So these are some of the differential diagnoses of persistent shock following primary PCI. Okay. Now, what are your management priorities for this patient now? What will you do now at this point of time? The question is always not straightforward. They would be creating complications and ask you to enumerate what you will do at the bedside, or as a the person attending in the ICU, what is your take home message, or how you are going to handle this complication, how you are going to handle this some or other rare scenario that is happening, and how you are going to counsel the family. So this is the essence of edict 2. So they will be starting from a clinical case scenario. In the clinical vignette 1, they will be trying to know the basic management plan for that particular case. Now in the clinical vignette 2 and 3, they will try to manipulate the case, create some complications, and try to know how confident you are in handling the case on day 1, day 2, day 3, day 7, something like that. So I would be again assessing fluid responsiveness, start inotrope, start cardiac output monitoring, considering the IABP at this point of time, because I have already done this patient the angiography as well as angioplasty, and so definitely I needs the support, hemodynamic support in the form of IABP. I will put the patient on NIV if the patient has not been intubated, give a trial of NIV. If the patient is still not tolerating and the deteriorating further, I will be going for invasive ventilation. So this is the management. Now, there would be a question at this point of time, how NIV help in managing cardiogenic pulmonary edema? Anyone? How NIV is helpful on loading? Decreases afterload, preload. Okay. PEEP open alveoli decreases afterload, decreases afterload. Everybody is saying preload, afterload. PEEP improve oxygenation. Very good. Very smart group. Okay. So decreases myocardial preload, decreases afterload, re-expands the flooded alveoli, improves VQ matching, reduces the work of breathing, and reduces heart rate by increased parasympathetic tone in response to lung inflation by CPAP. So this is the heart-lung interaction. So you are using NIV, that is actually reducing heart rate by increasing the parasympathetic tone, as you are actually inflating the lung with the CPAP. So that is exerting parasympathetic tone in the heart, and as a result, if the parasympathetic tone will be overactive, it will result in reducing the heart rate, and that is actually useful because your coronary circulation will be better, and your the afterload and preload would be optimized. Clear? Okay. Now, coming into the Vignet 2, you have done an echo, no pericardial effusion, ejection fraction is only 20%, globally poor systolic function. He was started on noradrenaline and dose escalated to zero point 0.2 mics per kilogram per minute. Despite this, his BP remains low. It did not improve on NIV, and you have decided and you have put on invasive mechanical ventilation. What is your plan of management now? Yeah, yeah, family counseling. Dobutamine. These are smart answers. I will be saying that what you are actually saying, inotrops. Okay. I want you to all share some other option. You don't have no option of hiding from the family. Okay. So they are in front of the ICU and waiting for you to come out of the ICU and tell something. Okay. Good. PCI again. Already the patient has been done with PCI, no? Okay. LVAD. Okay. Okay. Good. Everybody has actually tried to answer it. Very good. Mechanical circulatory support. Actually, at this point of time, you have already started on many things. Vasopressors, inotrops, intubated also, and angioplasty has been done. So definitely now there is role of mechanical circulatory support to start with maybe IABP, then VA ECMO, and ventilator assist device. Now this patient was put on IABP as you have all suggested. Now what are the potential complications of the IABP? It's a straightforward question, so I'm just highlighting the answer. Limb ischemia, bleeding, aortic dissection, balloon rupture, helium gas embolism. Now what are the pathophysiologic consequences if the IABP balloon inflates too early? I want answers from all of you. What are the pathophysiologic consequences if the IABP or balloon inflates too early? You will be getting one IABP for sure. In your EDIC 1 also, I think if somebody has appeared and cleared, IABP is a very favorite question for European diploma exam. So you have to read it in detail. I am also having this in my CCS, and I am sure Dr. Sanand in his CTVS or cardiac surgical also domain, he will be also describing in detail. IBP is a must. Okay, perfect. Many people have actually uh, tried to answer. Okay. Premature closure of aortic valve will happen. Already answered by many, resulting in what will happen? Inadequate left ventricular emptying. So left ventricle is unable to empty only. So as a result, what will happen? Decrease cardiac output, which we don't want only. We want to improve cardiac output. It will increase afterload because you are actually inflating too early. And as a result, what will happen? Myocardial oxygen demand like would be also very high. There would be decreased oxygen supply to the left ventricle due to decreased diastolic perfusion of LV. Why? Your balloon is actually inflating when the LV is still contracting and coronaries are squeezed. So that's why what will happen? When actually there would be a diastolic augmentation that is actually improving the coronary blood flow. But here coronary blood flow is unable to improve. So if it will not be improved, how come like no good amount of oxygen will come to the LV? Are you clear? So that is the whole point of mentioning that yes, you don't want that the balloon should be inflating too early. Clear? Now, there are many permutation combinations that you need to be thorough. I am just highlighting this early balloon inflation. What will happen? I have already discussed. So instead of here, it should have like no inflated here, but now what is happening? This aortic valve closes prematurely, systole ends prematurely, so LV emptying is incomplete, and this would be decreasing the cardiac output. Clear? Now there would be many things related to IBP. I'm not going into detail. They would be putting some or other picture in the CBS as well. So please go through this topic in your leisure time. IABP, what will be the normal arterial line waveform, where will be the IABP, the inflation, deflation, so all these diacritic notch, all these things have to be very clear. Now, what are the indications for IABP? One is to wait for recovery or breeze to the definitive procedure, like failure to come off bypass, severe aortic stenosis, mitral regurgitation, VST, cardiogenic shock while waiting for PCI, also reverse. You have done PCI, still the patient is in cardiogenic shock, and you are thinking to put on mechanical circulatory assist device for long term. So there also IBP comes handy. Pulmonary edema in spite of maximal medical management. There would be some prophylactic use like high risk PCI patients. Pre-operative also you will put the patient on IBP. And the trial is IBP shock true trial. And some or other like the CABG patients, pre-op only you are putting the patient on IBP, high risk pre-CABG patients with low ejection fraction. You are thinking the patient will be sinking on the table. So there also put the patient on IBP beforehand and then shift to OR. And totally experimental tachysupocardiomyopathy, neurogenic stress cardiomyopathy of subarachnoid hemorrhage. Now, what are the contraindication of IBP? Absolute contraindications are AR, aortic aneurysm, aortic dissection, severe sepsis, uncontrolled coagulopathy. Relative contraindication, atherosclerosis and arterial tortuosity, left ventricular outflow tract obstruction, and contraindications to the anticoagulation. Now, what are the possible complications? Already I have discussed. What are the abnormalities with IBP waveform encounter? All these things you have to read. I'm not going into detail. In the CTVS cardiovascular the domain, there would be more detailed discussion. So I am restricting myself to only the complications that would be happening or the situation where you will be getting the IBP faulty, early balloon inflation, late balloon inflation, early balloon deflation, late balloon deflation, and poor diastolic augmentation. Clear? So these are something I am just keeping because this would be taking time. If there would be early balloon deflation, what will happen? In one point, can you tell me if the balloon is deflating faster, what will happen? It would be failing to decrease the myocardial oxygen demand because you are actually not able to uh, keep the heart in the left ventricular isovolumetric contraction for a long time. So that's why there would be no decrease in the myocardial oxygen demand. There would be still some diastolic augmentation, but it would not be very effective. Clear? And late balloon deflation, what will happen? it would be still contracting against a closed aortic valve. So as a result, what will happen? There would be high aortic end diastolic pressure, and that would be leading to increase in the afterload and increase in the left ventricular oxygen consumption. So this would be lethal. We don't want this type of situation. You can see here, it is prolonged. The balloon is inflated for a longer time. So as a result, there would be increased aortic diastolic pressure. Clear? So increases afterload. This I am just skipping. Okay. Now, what are the indications for VA ECMO? Already discussed, but yes, you have to again remember cardiac arrest, failure to wean from CP bypass, cardiogenic shock with reversible pathology, and as a bridge to the heart transplantation. Now, Vignet 3. You are now taking round of another patient, and nurse called up urgently, and you check the monitor strip showing the following ECG. What is happening? What is happening here? And what will be the next step that you will be doing? Okay. Very good. So all of you are actually right. What are the immediate and preventive management that you will be doing? Immediately you start CPR and perform immediate defibrillation for the ventricular fibrillation. Administer IV amiodarone or lidocaine if your arrhythmia is persisting, because you have already started on high dose of adrenaline as well as vasopressors. Correct any reversible causes like hypokalemia, hypomagnesemia, or ischemia. And the preventive management at this point of time, if you are like going for the post MI patient, you have to optimize post MI management in terms of beta blocker, ACE inhibitor, antiplatelet therapy. You have to again check the prescription. Now consider implantable cardioverter defibrillator placement, that is ICD, if you are having frequent arrhythmias as well as the patient's heart is not pumping well. So definitely there is a role of ICD. And address ischemia with repeat angiography. Maybe this patient is going into the stent thrombosis or so that the patient is having arrhythmias again. Now, Vignet 3, after 8 cycles of CPR and ACLS in this patient, you are getting ROSC. 48 hours of post cardiac arrest, sedation was stopped, but the patient was unresponsive. His current GCS is E1, M2, and V1. Pupils are equal, reactive to light. His corneal reflexes are present. He is breathing spontaneously on the ventilator and coughs on the suctioning. You observe myoclonic jerks. CT of the brain is performed at 48 hours, which is normal. How will you manage this post cardiac arrest patient from the start? Now, though it is a cardiology domain, but it will not be restricted to the cardiology. So that's why I want to give you the experience how cardiology domain becomes a neurologic domain after 2 to 3 clinical vignettes. So that's why I have changed, though it is not neurology domain, but I want to feel how the cardiology domain turns to the neurologic domain. Okay, very good. Okay, so TTM and neuroprotective measures. Clear? Now, cause of myoclonic jerks and its prognostic significance. Definitely, we will be keeping in mind this patient has suffered anoxic brain damage, though the patient was on ventilator. How will you prognosticate to his family? Yes, this is like anoxic brain injury. Prognosis is poor but difficult to say at 48 hours. We need to continue supportive management and reassess after 72 to 96 hours. This is a standard format for post cardiac arrest management. On day 5 after cardiac arrest, the patient remains unconscious. His jerks disappeared, but the brainstem reflexes are absent. How will you proceed further? Any answer? EEG, MRI, okay. Apnea testing, brain death protocol, TCD, okay. Okay. Brain death testing, apnea test you should do, and ancillary testing, because already like 5 days have passed. So definitely all the other things are also right, but definitely you should keep that. Yes, this patient could be brain dead. Now, What are the prerequisite for brain death testing? This is straightforward things because neurologic domain will be definitely having similar questions. So I am just trying to summarize normothermia, normotension, exclusion of sedative drug effect, no residual neuromuscular paralysis, ability to examine the brainstem reflexes. There should not be like no that ears, eyes are like no not there in this patient. Ability to perform apnea testing. So these are the prerequisites for the brain death testing. Now, like what is the role, and like you can see here, like just 1 second. Yeah, name two landmark trials related to therapeutic hypothermia and targeted temperature management in out of hospital cardiac arrest patient. Can anybody just mention? Yeah, can you say what is TTM2 trial? Team 1 2, yeah, okay. Haka trial, TTM1, TTM2, Hyperion trial. Haka trial is like no, it's a multi-center randomized control trial. 273 the out of hospital cardiac arrest patient, VA for VT. 24 hours the patient was cooled to 22 to 34 degrees centigrade versus usual care, and they demonstrated favorable neurologic outcome. But there were some issues. 8% of the screen patients were included only, and the control group became hyperthermic. Mhm. Okay, so this is something very interesting trial in 2002. Now came 2013 TTM2 1 trial. Again, 939 patients of out of hospital cardiac arrest patient. 36 hours of cooling to 33 degrees centigrade versus 36 degrees centigrade with 72 hours of normothermia post ROSC. No benefit between the two arms, whether you are cooling or you are maintaining the temperature at 36 degree. Now came 2019 Hyperion trial, again multi-center randomized control trial. 584 patients of out of hospital cardiac arrest and in hospital cardiac arrest patients, non-suckable rhythm, 24 hours of 33 degree centigrade, then normothermia for 24 hours versus normothermia for 48 hours. So they have initially decrease the temperature to 33 degree, then again going up for 36 degree, and also there would be a comparison with the 36 degree centigrade for 48 hours. Demonstrated significantly improved neurologic outcome if you are actually treating the patient with hypothermia and then normothermia. But there were a lot of issues in the treatment arm. Then came 2021 TTM2 trial, where they have included 1861 of out of hospital cardiac arrest patients, 33 degrees centigrade for 28 hours, then rewarmed until 48 hours, then normothermia to 72 hours versus normothermia that is 36.5 to 37.7 degrees centigrade for 72 hours post RUSC. Demonstrated no significant difference both morbidity and mortality. So that was a negative trial for the hypothermia. So the consensus is euthermia, or rather not hypothermia. So with this we conclude the CCS part 1 and part 2. So how did you like both the two CCS? Are we justifying taking the cases and discussing in detail? Again, here I have tried to cover MI, the complications, again the management part, then some or other like the cardiac arrest related complications, then how to manage in the ICU a post cardiac arrest patient. Okay, perfect. So with this, we'll be going for the CBS. If you want for 1 minute break virtually, I'm just trying to again sharing my screen at this point of time. What is this shorter but frequent versions? I will be honest with you. There are like people who will be there. Like we have almost 50 plus candidates, but for live sessions they don't join. They have n number of reasons to say that we are busy. So if you are saying that frequent versions, that means in week we will be having again like 2 sessions. For one session, people are not joining, and then we will be going for 2 sessions. Are you getting my point? Not to offend anybody, but this is the hard reality. People want everything just in the in a crisp manner, but they will not be attending in the discussion, participating in the discussion. So that is the sad part. Okay. Okay, no worries. So we'll be again starting with our CBS. Okay, perfect. Books are plentifully available, but creating this type of CCS is the difficult part, Dr. Mohammed. I completely understand that you are like asking about any book. Nobody has actually come up with typical CCS books yet. Only our academy has tried to create the CCS by frequent thinking how to make CCS interesting, and we are also getting the response from our candidates that in the exam also they are also getting similar things from the real addictive examiners. Okay, no worries. So without wasting further time, we have to again respect our time. So let's start with CBS part. I've created few things that do we think that the ticket to success is so simple? No, it's not hard work, rather it is smart work. That is the ticket to success. And everybody has to work smartly for this type of exam. Now, CBS cardiology, I will not be explaining the concept or the basics because in the exam, it is only 1 minute per question. Remember, try to keep that in mind. It may not be exactly 1 minute. You can go for 90 seconds in some questions, 60 seconds in some question. But if you're keeping 1 minute per question, then only your reflexes will be sharp. Otherwise, you will be struggling in the exam. If a table viva or station will be having 10 question in 10 minutes, you will be only able to finish 6 or 7 with confidence. The last questions would be just the I would say you are skipping, and the last question would be the easiest one. So that we don't want you to do. So rather only keep 1 minute time for each question when you are looking at any CBS question. Okay. I would be letting you know high topics or domains in cardiology through this CBS. I will try to clear concept little bit, but not very much because it will be again taking much time. Strongly advise. We have already mentioned in multiple times in our free introductory webinars also, prepare your own question banks. It's not that a book will be giving you everything. No, it will not be having a single book where you will be getting everything in total. It's the your own preparation that will be making it easier for your revision time last month before the exam. Clue 5, revise, and some or other questions you feel that it is very difficult or atypical, it may will not come anytime, but we are just creating these questions to keep you on your toes. If we will be only giving you simple questions, then you will not be making your reflexes sharper. So that is the reason, and we are also trying to go with the latest trend. Edic 2 is coming up with also some of the difficult questions recently. Okay. Okay, so I have created all those questions we have already said, but I am now trying to give you the high yield domains for you to start preparing in a better way. So all the questions, there will not be having any nomenclature or the naming of that question, that from which domain of cardiology this question has come. But I have tried to give you this beforehand so that you should remember that heart failure or diastolic dysfunction is one important subdomain of cardiology. Okay, now the question that we have asked you, a 68-year-old female with a history of hypertension and type 2 diabetes presents with exertional dyspnea and fatigue for the past 2 months. She denies chest pain or palpitation. Okay, on examination, her BP is 150 by 85, heart rate is 82, and there are bilateral vessel crackles. ECG showed LVH, and echocardiography you have done at the bedside that revealed normal ejection fraction, EF 60%, concentric LVH and elevated left atrial volume index. Doppler analysis that was also done during the echo that showed E by A ratio less than 0.8 and E by E dash ratio of 16. Question 1. What is the most likely diagnosis based on the clinical and echocardiography finding? And what are the key management strategy for this patient? I want answers from you. Okay. So you all have decided that you will be answering one part and the other part person will be answering the other part, and you will be combining this, and the examiner will be marking based on compilation of all the answers. Most likely diagnosis first. Management part you are okay. I got your point that you are adding to the question, the answers that have been already mentioned by the your friends, colleagues. Okay, perfect. But you are all trying it and reaching to 90%. That is a very encouraging and motivating factor for like us also and for you also. So most likely diagnosis, complete diagnosis, always try to answer heart failure with preserved ejection fraction due to diastolic dysfunction. And what is the like no the there is a question like no what is the key findings here? So the key findings, just for the sake of like understanding, we are getting normal ejection fraction here, left ventricular hypertrophy, elevated E by E dash ratio, which is indicative of high filling pressure, and an abnormal E by A ratio. E by A ratio will be for impaired relaxation, and E by E dash ratio elevated is for high filling pressure. Clear? Now, I'm just highlighting what would be the echocardiography finding of heart failure with preserved ejection fraction. Definitely, as it is preserved ejection fraction, typically it would be more than equal to 50%. LVH would be there because it is increased afterload. As a result, there would be concentric hypertrophy. Diastolic dysfunction would be there. Diastolic dysfunction will be characterized by two things. E by A ratio would be less than 0.8 in early diastolic dysfunction, that is grade 1. If you are getting E by A ratio more than 2, it would be pointing towards severe dysfunction, that is grade 3. That is pseudo-normal or restrictive filling pattern. Clear? Now, increased left atrial volume index more than 34 ml per meter square indicates chronic elevation in the left atrial pressure. Elevated E by E dash ratio more than 15, that would be suggesting elevated LV diastolic pressure. You will be also getting sometimes pulmonary hypertension because of increased left atrial pressure. There would be back pressure, and you will be getting elevated PASP, that is pulmonary artery systolic pressure, and there would be also sometimes terminology named as global longitudinal strain. So despite your normal LVEF, you will be getting subtle impairment in the global longitudinal strain. So this is the classical finding, echocardiography finding in a case where it would be heart failure with preserved ejection fraction. Now, what are the key management strategies for this patient? You have already mentioned BP control, diuresis in the form of diuretic furosemide. What is the reason why you are actually opting this? That has been mentioned, not going into detail. Heart rate control in the with the use of beta blockers or non-hydropyridine calcium channel blockers, deltiazem. Comorbidity management, if the patient is coming again in your OPD practice, in your like follow-up practice, you have to advise for the comorbidity management as well as lifestyle modification, because these are something which is again contributing to this diastolic dysfunction, like diabetes, obesity, atrial fibrillation, which are frequent contributor to your heart failure with ejection fraction. Now, question number 2, I have chosen cardiorenal syndrome, which is one upcoming subdomain of cardiology, which you should remember in detail. Now, the question is, here it would be looking easy. I know everybody will be answering that this is cardiorenal syndrome, but in an examination, this yellow part will not be there. It would be the question itself. You have to only say that this is cardiorenal syndrome. So don't take it easily. Okay. A 65-year-old male with history of ischemic cardiomyopathy, ejection fraction 30%, with CKD stage 3, presents with worsening dyspnea, lower limb swelling, and reduced urine output over the past 48 hours. You examine the patient, BP is 90/60, heart failure, heart rate of 105, elevated JBP, bilateral vessel lung crackles, and pitting edema up to the knees. Lab results showing serum creatinine increased from 1.8 baseline to 2.5, and PNP is 1200 picogram per ml. Question 1: what is the most likely diagnosis and what are the key principles of management for this patient? Answers, please. Okay. As it is written cardiorenal syndrome, nobody wants to actually answer, but there is a better answer than cardiorenal syndrome also. Yes, I was expecting that you will write cardiorenal syndrome, but it is not the typical cardiorenal syndrome. You have to again classify which type of cardiorenal syndrome this is, and there it will be important to know what are the types of cardiorenal syndrome. Can anybody name it? Can you classify cardiorenal syndrome? Okay, 5 types. Okay, 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 good, good. Okay, okay. So though the CKD is stage 3, but this has been actually resulted in like no very short time. So maybe it is acute or acute on chronic cardiorenal syndrome. So both type 1, like no, the heart is the culprit, and that is actually resulting in the renal problem. So it is caused by acute decompensated heart failure leading to acute kidney injury. Though it is CKD stage 3B, but the patient is not oliguric. Okay. Now, what are the key principles of management for this patient? Hemodynamic stabilization. Everybody knows norepinephrine if your hypotension is persisting after adequate fluid resuscitation. Diuretic therapy. Yes, we need to reduce the congestion part here. Renal support in the form of, despite the patient's creatinine is high, but we need to optimize renal perfusion by balancing the fluid removal with whatever existing kidney function it has. So we should not be bothered about the creatinine. So we need to go for diuretic first. If diuretics are ineffective, we will be increasing the diuretic dose. If it is still not effective, we will be going for ultrafiltration. Clear? And then cardiac support. We have to think about, if despite all these things you are getting evidence of low cardiac output as well as hypoperfusion still existing, we need to think about cardiac support. And all these things would be resulting in like the potassium sodium as well as acid base imbalance. So we have to monitor electrolytes and ABG frequently. Now just for all of your understanding, you have all mentioned the types of cardiorenal syndrome: acute cardiorenal, chronic cardiorenal. So if heart is the culprit, first culprit, so it would be 1 and 2, acute and chronic. Remember it. Now if kidney is the culprit first, and then that is actually having effect on the heart, so it would be 3 and 4, acute and chronic. Nephrocardiac. So remember, cardio 1 2, acute chronic. Nephro acute chronic 3 and 4, and fifth is secondary, and secondary is everything related to sepsis, vasculitis, diabetes, everything. Okay, the systemic diseases that is actually leading to heart and kidney failure. Now third point is related to cardiogenic shock. We have already discussed. I'm just showing you the question that can come in the CBS as well. 58-year-old man with no previous comorbidity, ST elevation 2-3 ABA, heart rate 56, BP 75/55, saturation of 96%, bedside echo, right ventricular dilatation and dysfunction. The patient is intubated, started on mechanical ventilation. Despite you have increased the dobutamine and epinephrine, patient is still having cardiogenic shock with rising lactate and decreasing urine output. Clear? Now, what is the next best step in management of this patient? We have already discussed, but the question needs you to again understand that we have the option of IABP, Impella, VB ECMO, VA ECMO, right-sided VAD. So what will be your choice in this patient? Rather, I would be saying it is one MCQ. Out of all these things, these are mechanical circulatory assist device. What is the preferred modality that you will choose and why? The next question would be why. Mm-hmm. Question again. Okay, okay, okay. No reach. Hmm. Okay. So what is the diagnosis here? This is a case where it is right-sided cardiogenic shock and failing inotropic support. That we all agree, because you can see here the problem, the cardiogenic shock is due to bedside echo, right ventricular dilatation and dysfunction. And also you can see here the patient was intubated on mechanical ventilation. So despite all these things, there is right now problem with the heart as well as lung. So out of these things, what will be the best modality that will be support the heart and lung? Next best, I would say. Okay, I will be going one by one. IABP or Impella are viable options for left ventricular failure. You all are right. VV ECMO offers respiratory support, but no hemodynamic support. But here there is cardiogenic shock also. Clear? Durable right ventricular assist device is much more invasive and would be premature, given that RV function may improve with appropriate support. Again, very valid point. If you are supporting with like the your cardiac support as well as lung support for some time, maybe the right ventricle will be start functioning well. So ventricular assist device would be something which would not be immediate next best. Okay. Now, the most important thing that would be right now appropriate here is VA ECMO. Why? This would be providing both pulmonary and cardiac support. So it would be also decongesting the right side of the heart and also infusing it to the arterial circulation, bypassing the heart and lungs. So you are actually giving rest to both heart and lung for some time, and that is the need of the hour here. Clear? Now, question number 4 here. ACLS rhythm, cardiac arrest, ECG. You will be getting a lot of questions on ECG. So that's why I have created more questions on the ECG and ACLS rhythm. You got a call to see a patient on the ward who has return of spontaneous circulation following cardiac arrest. The patient is groaning. On initial assessment, what you find? Patent airway, bilateral equal chest movement with good air entry, respiratory rate of 18 breaths per minute, saturation 94% on high flow oxygen. Heart rate is 45 per minute post cardiac arrest. Poor pulse volume, BP is low, 57 by 30. Conscious but not fully alert, RBS is okay. ECG done, which showed this one. What is the ECG rhythm? Diagnosis and immediate treatment. Please tell me the answers so that we'll be going quickly. Okay. Mm-hmm. Okay. Good. Complete heart block. The diagnosis, the ECG rhythm diagnosis is complete heart block. But if the question is for like diagnosis, so I will be talking about post cardiac arrest, complete heart block, patient is in cardiogenic shock. Clear? Immediate treatment, injection atropine, maximum up to 3 milligram, injection isoprenaline, injection adrenaline, fluid resuscitation, transvenous pacing or transcutaneous pacing. Here we have asked about immediate treatment. It is not the definitive treatment. The question, you have to understand the question here. And the complete diagnosis is not the ECG diagnosis. Try to understand what I am actually trying to highlight here. ECG high diagnosis is complete heart block, but the diagnosis, clinical diagnosis is post cardiac arrest, complete heart block, and cardiogenic shock. Clear? Now, just want to highlight few things. Immediate post cardiac arrest, if you are going for resuscitation, doing ACLS, and reviving the patient, the type of post cardiac arrest rhythm should not be labeled. This is one very important article that is published recently, 2023 only, and they have actually highlighted that you should not be fooled with the type of ECG rhythm. Rather, you should focus on the end organ perfusion or the hypotension, taking care of the hypotension. So that's why they have like shared one algorithm where post ROSC, return of spontaneous circulation, you have to check whether your systolic blood pressure is more than 90. So if it is less than 90, go with fluid bolus. If still you are not improving your blood pressure, it is like no, there is persistence of the hypotension, then you have to start vasopressor or inotropic. At this point of time, if you are already giving fluid, you are taking care of the blood pressure, then monitor the heart rate. If it is less than 50 per minute, then start adrenaline and titrate with the blood pressure. If it is more than 150 heart rate, then noradrenaline or phenylephrine, titrate to the blood pressure. So this is something highlighting that choosing the appropriate vasopressor or inotropic agent to treat hypotension after recovering from cardiac arrest rather than treating the tachycardia. So highlight of this presentation or this article is that post ROSC, don't try to only label that what is the rhythm. Rather, you should be trying to improve the blood pressure and then the heart rate and simultaneously other measures of post cardiac arrest rhythm. Now, related to complete heart block, I think everybody knows severe bradycardia. The ECG would be showing complete AV dissociation where atria is running in its own pace, ventricle is running its own pace. And this is the typical ECG of complete heart block. You can see here atria, ventricles are actually having their own rhythm. So atrial rate is 100, ventricular rate is 40. So it is complete AV dissociation. And the perfusing rhythm here, the patient is conscious, having patent airway and talking is due to the junctional or the ventricular escape rhythm, right? But you need to act quickly for the transvenous or transcutaneous pacing. Alternatively, the patient will be like suffering ventricular standstill leading to syncope or sudden cardiac death if you are actually delaying in your management. For all of you, I am just trying to highlight the ECG patterns are divided into arrhythmias and peri-arrest rhythm, heart block 1, ischemic rhythm, that is all types of MI, metabolic rhythm, hyperkalemia, hypercalcemia, hypothermia, digoxin, TCA toxicity, temporary pacemaker rhythm, where they will be having all types of ineffective capture, pacing, VBI pacing, DD pacing. Now finally syndromic rhythm. In syndromes, they can ask you Valencia, Brugada syndrome, short and long QT, WPW syndrome, pulmonary embolism, pericardial effusion, sometimes dextrocardia or lead reversal. That is also one thing that they can ask you. Clear? Now, I am giving you a very important clue here, how to approach any ECG. Determine what type of ECG is out of all this. There are major 5 here. If your ECG that is being asked in the exam is coming in this major 5 based on the history and data, then think of the differentials and the issue is resolved. If nothing is right now coming in these 5 major divisions as well, probably you are dealing with something called as syndromic. So you don't have a typical MI or typical hypokalemia, typical BF or pacemaker rhythm. Clear? So this is something, a clue how to approach the ECG patterns in any of the clinical examination, not only the critical care. Now, pulmonary embolism or POCUS, the next most important thing, we have already heard a very extensive long case or like the CCS. So I'm not going into detail. I will be just showing you the question. So a 55-year-old woman, man with poorly controlled type 2 diabetes, shifted to medicine floor with 1 week history of worsening diabetic leg ulcer. At the time of admission, patient was febrile, heart rate was 110, BP was 100 by 60. Patient is having saturation 95%. His left leg is swollen and tender, and patient was fluid resuscitated. Antibiotics were started. Now, on day 2, patient GCS worsened, though his fever and tachycardia have resolved. Creatinine is right now 3.4. Repeat vital, BP is 88 by 59, SpO2 is 90% on 4 liter oxygen. You shifted the patient to the ICU, patient became more hypoxic, you intubated the patient, started on norepinephrine, and POCUS is performed that showed lung sliding on both sides. And this is the typical bedside transthoracic echo that you have actually got. Now tell me what is the diagnosis and further management. I think everybody knows it. I'm just trying to again show you the slide. Everything has been discussed in detail, but CBS you will get a case of pulmonary embolism. There is a very high probability. So that's why it is fitting into the pulmonary embolism, and thrombolytic therapy is indicated if there are no contraindications. Clear? 6 is ECG. Patient found unresponsive. ECG obtained by TMT team is EMT team is below. Now you tell me the diagnosis, ECG diagnosis and management. I have highlighted also for you to look at the ECG changes. Already discussed in my CCS case discussion. So this is that you have to think about whether it is push pull effect. So I have tried to give you a clue from life in the first lane. Hypokalemia, it would be pushing. You see, you are actually pushing the ECG at the after the QRS complex, so you are actually resulting in the T wave inversion, ST depression, prominent U wave, which is hypokalemia. Now hyperkalemia, you are actually pulling it, pull up, and that is resulting in peaked T wave, P wave flattening, PR prolonged, and wide QRS complex. Clear? So in our patient, it is hypokalemia. I will be just showing you again. Are you getting it? Okay. So notable findings would be prolonged PR interval, ST depression, and U wave, and that is specifically seen in V2 to V4. Hyperkalemia, it would be peak T wave, prolonged QRS interval, and shortened QT interval. Hypocalcemia, it would be prolonged QT, and hypercalcemia, shortened QT. Just remember, hypo would be prolonged QT, hypo will be shortened QT. Hypermagnesemia will be similar to those seen in hyperkalemia. And the treatment for hypokalemia is IV KCl and injection magnesium sulfate. Now there are certain symptomatic hypokalemia, few things you need to remember. Just highlighting, never give KCl directly IV and use isotonic saline. Do not mix with dextrose containing solution because it will again result in hypokalemia. You are adding dextrose, that would be a change in the transport of potassium intracellularly. Clear? Now the next question is pacemaker. I am not going into detail because that would be again in detail discussed in the cardiothoracic domain. I am just asking you the question. A temporary pacing wire is inserted due to the recurrent syncopal attack in our 75-year-old patient with ischemic heart disease. Now, there are a lot of drug history here written: bisoprolol, ramipril, spironolactone, and furosemide. Now, the questions are, how could you describe temporary pacing wares using the first three positions of the British pacing and electrophysiology group? And with reference to pacemaker functionality, what is rate modulation? And a question again will be, what action should be taken when defibrillating a patient with permanent pacemaker. I will be showing you the points here, but again, I will not be discussing in detail. Pacing will be discussed in detail in the cardiovascular model, the surgical. Okay. Now, the answer to question number A, VBI is for demand pacing, that is paced ventricle V, sense ventricle V, and I is for inhibited if native activity is sensed. If you are asking VOO, what is the meaning? It is paced ventricle, but there is no sensing. Clear? Now, what is rate modulation? Can anybody tell me? This is ability of the pacemaker to alter the rate based on the physiologic demand. Like your heart needs more like of cardiac output. So the pacemaker would be alerting or altering the rate at which previously it was actually paced. So that is the point related to rate modulation. Now, when you are actually defibrillating a patient who is already having pacemaker, what are the precautions you should take? So the defibrillator pads should be placed as far as from the pacing box. This is point number one. Clear? And post defibrillation, you have to immediately check that the pacemaker settings are in proper like the way working and the functionality is good. This is the two things that you need to do when you are actually defibrillating any patient with pacemaker. Okay, I'm just skipping this because this would be discussed in detail in the cardiothoracic version. Now, there is a question number 8, Takotsubo cardiomyopathy. A 51-year-old woman presents after a fall with resultant left femoral neck fracture. The patient has no prior medical history and lives independently. While awaiting the surgical repair, the patient complains of chest pain. EKG is non-revealing, but echo you have done that is demonstrating dilated LV with ejection fraction 25%. The patient undergoes a left heart catheterization immediately in the cath lab, and this is the left ventriculogram that is being shown here. So the answer is already mentioned, but Takotsubo cardiomyopathy is a very important subdomain in cardiology. And the POCOS finding would be typical of pulmonary congestion. IVC is full, and you can see here the typical Takotsubo cardiomyopathy echo finding. So the most probable diagnosis I have already mentioned. Just showing you the answers. What is the typical left ventriculogram in a case of Takotsubo cardiomyopathy is classic LV apical ballooning. And from the history itself, you will get there would be a stressful event that has happened and the patient presented with cardiac symptoms and there is reduced left ventricular ejection fraction. In the coronary catheterization, you will get normal coronary catheterization. That is confirmatory of Takotsubo cardiomyopathy. This disease is self-limited and the LV function will be typically improving with supportive therapy. And stress cardiomyopathy is most common among post-menopausal women. I'm just skipping this. Now, question number 9. Pharmacotherapy, renal ECG. All the things have been included in this question. A 62-year-old woman has been admitted to the ICU with hypotension and bradycardia following 4-day diarrheal illness with vomiting. She is in acute renal failure with serum potassium level of 6.9 millimole per liter. So definitely the potassium is very high. Her medication history is unknown. His ECG is shown like this. Okay. Now, what abnormalities are shown on the ECG and what is the most likely cause of the bradycardia? So this is definitely having the bradycardia and the ECG is showing this. So ventricular bradycardia, atrial tachycardia, AV block, reverse tick, ST segment changes. You can see here. This is reverse T ST segment changes here. And this is classical with digoxin toxicity. And that is exacerbated by acute renal failure. From the history, you can see patient was admitted to the ICU, hypotension, bradycardia. There was like 4-day diarrheal illness, vomiting, acute renal failure, potassium is rising 6.9 millimole, and all the types of ECG changes are actually supporting the diagnosis of digoxin toxicity. Now, I am just showing you the classic digoxin toxic dysrhythmia, which would be supraventricular tachycardia, slow ventricular response, and any type of block and atrial fibrillation would be there in the digoxin toxicity. Now, I am just showing you the typical digoxin effect, that is sagging ST. Sagging ST, what do you mean by that? It would be resolving reverse tick sign. This is the typical reverse tick sign and also named as the Salvador Dali sagging. Just one. Yeah, okay, sorry. So now you can see here the typical ECG signs of digoxin toxicity is Salvador Dali sagging or reverse tick sign. Now, 10th question is PAC, pulmonary artery catheterization. Why I have kept one question from the pulmonary artery catheterization? Because this is typical of cardiology part. A 68-year-old obese man with diabetes mellitus, hypertension, and coronary artery disease was admitted 5 days ago for anterior STEMI. Now, coronary angiography was performed with a bare metal stent placed in a completely occluded left anterior descending artery. He was discharged yesterday, but was brought back to the ED today with altered mental status and severe dyspnea. Now, vitals are heart rate 120, BP 85 by 50, respiratory rate 27, and saturation is 90% on 6-liter nasal cannula. The most important thing here in this CBS question that you are, when auscultating, you are getting new loud, harsh, hollow systolic murmur at the left lower sternal bladder. EKG was done, which was unchanged compared to the EKG on the day of discharge. TT is attempted, but you could not do a proper TT because of the body habitus. Now you have actually put PA catheter in this patient, and the following numbers are obtained. Right atrium pressure 14, oxygen saturation 56. Right ventricle 54 by 12 and oxygen saturation is 82. Pulmonary artery 54 by 33 with 82 saturation. Now pulmonary capillary wedge pressure is 25 millimeter mercury with V waves noted. Clear? Now what is the cause of shock and the management? Can anybody tell me? Yeah, very good. Yeah. So the classic finding I have actually highlighted in the red color, that is VST. Okay. So here you can see the VST. There would be typical PA catheter finding, which is step up of oxygen saturation between right atrium and right ventricle at the level of the shunt. That is actually the shunt is actually causing the step up of the oxygen saturation. So this needs surgical intervention. This needs surgical intervention here. Now, initial stabilization you have to do with vasodilators, inotropic agents, diuretics, and IBP. But surgery is the treatment. Now, this can also present with systolic murmur, like the papillary muscle rupture, acute MR, all other complications like mechanical complications of anterior, like the acute myocardial infarction, are you can say in the DD here. But the most important point here, which will be supporting our diagnosis of VSD, is the step up of oxygen saturation. Clear? Now, there is another ECG. 52-year-old man has been brought to the ER. Patient was found collapsed next to a canal. He is dressed in multiple layers of cold, wet, and dirty clothing. He has heart rate of 48 beats per minute, BP of 88 by 54, GCS is 9. Paramedics have been unable to obtain a temperature reading. Now ECG done, that is showing this. What is the ECG diagnosis from this case? There are multiple clues that have been given in this clinical vignette. Perfect. So everybody knows it. From ECG, you will get definitely one or two questions. Okay. So these are like, the abnormality is the Osborn wave. The DD can be not only hypothermia, but there would be also other causes like hypercalcemia, brain injury, subarachnoid hemorrhage, vasospastic angina, type 1 Brugada syndrome, normal variant also. Sometimes you can also see that normal variant. And what changes are made to the ACLS algorithm when you are resuscitating a patient with hypothermia? That no adrenaline or other drugs until your patient temperature is more than 30 degree. Between 30 to 35 degree, always double the dose interval for advanced life support. Shock ventricular fibrillation up to 3 times if necessary. Then no further shock until the temperature is more than 30 degrees centigrade. So you can initially give it, but you have to maintain the temperature more than 30 degrees centigrade, because otherwise your drugs that you are giving, the defibrillation that you are giving, it is not going to be effective. Clear? Now, once cardiac arrest is confirmed, then you have to reworm this patient as fast as possible. Look for other the alternative diagnosis, and you have to anticipate prolonged resuscitation. So that would be like you have to involve many people. In a case of hypothermia, it is not going to be helpful for 30 minutes or 45 minutes. Maybe you have to continue your resuscitation for more than 1 hour. Clear? Now, this is something very important, that defibrillation is less effective in hypothermia. Pacing is generally ineffective, because do not try it unless bradycardia persists when normothermia is reached. Now, ventilation, normocapnia will be achieved at lower minute volume than normal, and hyperventilation risk cerebral hypoxia. Aim for a normal carbon dioxide on ABG, and that has to be again not corrected for the patient's temperature. Now, intubation, again, you have to be very sure, otherwise what will happen? Slight rough handling of this patient, hypothermic patient can precipitate with the ventricular fibrillation. Resuscitation drugs, we all know they are often ineffective and will undergo reduced metabolism. So withhold, withhold these medications below 30 degrees centigrade. Then you give twice the interval, a time interval between doses, until you are getting either normothermia or circulation is restored. You have to remember, they may ask you this question. And adrenaline would be given about every 8 to 10 minutes once the core temperature is above 30 degree. Don't give frequently, as mentioned in the normal ACLS algorithm. Then chest compression, hypothermia will be creating muscular stiffness. So chest compression will be like harder than normal. Rewarming, that can be passive or active. In a case where the patient is still having perfusing rhythm, passive measures may be sufficient, and passive measures will only achieve rewarming in a patient with effective circulation. If your patient is not having effective circulation, so the passive measures will not be effective. Rather, you have to go for the active measures. Remove wet clothing, dry the patient, cover the patient with forced air warming blanket. And in case you are still not getting the internal rewarming as per your expectation, think about cardiopulmonary bypass. Okay, so the therapeutic maneuver of choice in case of hypothermia to maintain or improving your temperature, core temperature to normal temperature, is cardiopulmonary bypass. Clear? And the temperature will be increased 1 to 2 degrees centigrade every 5 minutes, so that you will be getting the core temperature to be having euthermia. Clear? I'm just skipping. Now, question number 12, again, a pulmonary artery catheter. The question here is, can you just like say you are managing a patient with severe systolic heart failure and septic shock in your ICU. While attempting to obtain a wedge pressure, you see the following tracing after inflating 1 ml of air into the balloon. What is the problem, cause, and next best step in the management? Can anybody tell me what is happening? You are inflating 1 ml of air into the balloon, and then you are actually trying to obtain the wedge pressure, but you are getting this type of tracing. What is happening? The clue I have already written as like no in the yellow, that is PSC, pulmonary artery catheter. Okay, anybody? Anybody related to this question? Okay. Now deflate the balloon and pull back to obtain pulmonary artery tracing. This tracing is because of continuous increase in the pressure with the balloon inflated consistent with an overweight position. And actually this could be due to trapping of this balloon against the vessel wall, and in this position the pressure increases due to continuous flow of the flush fluid to the catheter tip. And this overweight position, if you are continuously keeping or maintaining for long time, there is increased risk of vessel rupture. Clear? And this is the thing that you need to remember. As EDIC 1 you have already cleared, so you know how important PA catheter for the European examiners. They are very emotional about PA catheters. They will try to keep 1 or 2 questions in EDIC 1 as well as in EDIC 2. So you have to know about how the tracing will be there in PA, pulmonary artery, right ventricular pressure, then like the pulmonary artery occlusion pressure, how it would be looking like, what will be the pressure range. This is a article, very good article, Contemporary Pulmonary Artery Catheter Placement and Waveform Analysis, published recently, 2022 only. You can read in your leisure time. Now, next question is aortic dissection. I am just showing you the question. It's a very straightforward question. 56-year-old male, chronic smoker, uncontrolled hypertensive, presented to the ER with acute onset chest pain, radiating to back. CT scan was done. That is showing this one. Identify the abnormality and management. It was actually asked in the real edict 2 also. Straightforward question. Aortic dissection, medical management and surgical management, but you need to know which type of aortic dissection is this. If it is type A, definitely surgical intervention. Type B, complicated surgical intervention, you should prefer endovascular repair. Uncomplicated, medical management. Then you have to know about what is the classification of aortic dissection, what are the things that you need to remember when you are going for the diagnostic imaging, how you will be stabilizing these patients. All these things are asked in the aortic dissection part. And this is a very good article again, Journal of Intensive Care Society, Management of Aortic Dissection, Acute in Critical Care, published in 2023. Now question number 14, MI ECG. I am just telling you the question. You can see what is happening here. Can anybody tell me what is the ECG diagnosis and what is the definitive management? What is the ECG diagnosis and the definitive management here? We have 6 questions more to go. The 20 questions are there. So it is anterior wall MI and the definitive management is PCI. Again, I have discussed in detail this one, not going into again all these things. You have to remember the area of infarction, the ECG leads and the infarct related artery. Now coming to the cardiac pharmacology, I am talking about a drug which is inhibiting phosphodiesterase 3 enzyme by decreasing cyclic AMP hydrolysis. It works as an inodilator. Which drug we are talking about and what is its effect on the right side of the heart? Anyone? Yeah. And what is its effect on right side of the heart? Answer is Milrinol. You are right. Improve contractility of right ventricle. It is a pulmonary vasodilator, reduced afterload for the right heart, and also a peripheral vasodilator, reducing preload to the right ventricle. So as a like it's a peripheral vasodilator, the preload to the right ventricle will be decreased. That is also a good point. And then it will be also reducing the afterload by pulmonary vasodilatation. And also it has some lysiotropic action. Not going into again detail. There are other the vasodilator, pulmonary vasodilators in the form of nitric oxide inhaled, milrinone, prostaglandins, sildenafil. And the mechanism of action also we all know. They may ask you related to CCS also and CPS also. Now, this is again related to cardiac pharmacology. What is the mechanism of action of this drug and what are the two important side effects? Can anybody tell me? What is the mechanism of action of protamine? Mhm. Okay. So mechanism of action is not heparin antagonism. It is highly cationic peptide that binds to either heparin or low molecular weight heparin to form a stable ion pair which doesn't have any anticoagulation effective activity. And this the compound which will be like formed by this binding is then removed and broken down by the reticuloendothelial system. Yes, you are right that it is heparin antagonist, but you have to mention the mechanism of action and the complication. It can cause pulmonary vasoconstriction leading to pulmonary hypertension, bronchoconstriction, bradycardia, negatively impacting the platelet function, interfere with the coagulation factor, and decrease the thrombin fibrinolysis mechanism. Clear? Now, question number 17 is 40 years male HR executive comes for a routine investigation for insurance. EKG done in the ER has been sent to you for evaluation. Now you can see here ECG diagnosis and treatment. Can anybody tell me? Sorry. What is the ECG diagnosis here and the treatment? Testrocardia. Interesting. Lead reversal. Yeah. Yeah. You are right. Like no, both the two things are right, but yes. Uh, Here you can write lead reversal also dextrocardia and the treatment is non-required, nothing is required. You have to just counsel the patient. 18 number question. 28-year-old male, known carcinoid syndrome, presented with vomiting, shortness of breath, tachycardia and palpitation. You have attached multipara monitor and you are getting this monitor finding. Focus is on the CVP. Okay. Now, finding and intervention. What is happening here? I'm just making it clear for you. There is fusion of the C and V wave. ACV, X and Y descent. So CVP is very interesting. It is looking like arterial waveform because you are actually getting the fusion of the C and V wave, and that is suggestive of tricuspid regurgitation. And this tricuspid regurgitation is associated with right-sided carcinoid in heart. You can see here carcinoid has been written in the clinical vignette also. So definitely that is resulting in the TR, and that TR is resulting in the fusion of the C and V wave in the CBP. What will you do? You will be ordering one 2D echo and you will be doing the 2D echo to know more detail about the clinical condition and get one surgical review immediately. Maybe the patient needs surgical correction. 19 number related to cardiac tamponade. A 66-year-old male smoker while driving car had head-on collision with a truck and sustained blunt chest injury. Admitted to the emergency department with shock, and these are the echo finding. Very suggestive. I have just kept it because it is very important domain in cardiology part. So what is the differential diagnosis? Differential diagnosis: ventricular rupture could be there, aortic dissection could be there, pericardial effusion with tamponade could be there because of the high velocity injury. What is the treatment? Pericardial tapping urgently, and then maybe the patient will be subjected to thoracotomy and the repair. Question number 20. 70-year-old man presented with dizziness and near syncope. Now this is the ECG. What is happening here? ECG diagnosis and treatment. Anybody? Okay, I'm just making it very clear. This is one type of block and which is second degree Mobis type 1. Wenke back. phenomenon. And just to highlight here, Mobis type 1 is often the treatment is not necessary, and you have the type 1 and type 2. And type 2 you have to involving the cardiologist, you have to involve your the senior most person or the person who is doing the pacing as soon as this rhythm is identified. And type 2 blocks the the structural damage already has happened to the AV conduction system, and that would be maybe deteriorating into the complete heart block soon. So unlike the type 1, patients that are bradycardic and hypotensive with a type 2 rhythm often do not respond to atropine. So type 2 is little bit more dangerous than the type 1, where the treatment is often not necessary and these patients would be responding well to the atropine. If not, then definitely you will be offering them transcutaneous or transvenous pacing. Now the last question of the session: 62-year-old female patient, known diabetic, hypertensive, coronary artery disease, and recurrent AFib in cardiac ICU is managed with NIV, diuretics, fluid restriction, antiplatelet, digoxin, oral antidiabetics, and amiodarone. The resident texted you recent ECG as shown below. What is the ECG diagnosis? What could be the cause and mechanism of this ECG and the emergency treatment? Anybody? Patient is a known case of diabetic, hypertensive, and coronary artery disease, recurrent AF, and having lot of medications. And patient is on AF, and NIV. Patient is also on NIV, and this is the ECG you are getting. Okay, good. There are multiple correct answers. So this is something related to the torsades de pointes because of prolongation of the QT. And the prolongation of QT, what is the region of prolongation of QT in this patient? Can anybody tell me? Why this patient is actually, yes, drugs. This is a broad answer, no? Drugs. Which is the drug among all these drugs that would be increasing the prolongation or the increasing the duration of the QT? Amiodarone. Yes, excellent. Yes, your answer should be framed in this manner. So you should not be very non-specific, though you will feel that you have answered, but your answers will not fetch any mark. Okay. And emergency treatment, we all know, injection magnesium sulfate. Thank you very much. I know it was a long session, but we tried to include maximum number of questions that can be asked to set you in the very first instance of our preparatory course, that is the cardiology. I know there were a lot of repetitions I tried to do, but these are very important. If you frequently attempt this question only, your reflexes will be sharp, so that you in the examination, when the examiner would be there, it is a high voltage exam, the question and answer has to be in minute only, so you can answer, otherwise you would be lost in the jungle, right? So my whole idea, I have given you the clue, then only the question, so it becomes also a little bit difficult. But in the real exam, there would be no clue, and the examiner will be also having no expressions, minimal expressions, so you will feel that actually you are doing something wrong, or your answer is right or wrong. So they would be just clueless. Their face will be having no emotions, so you will sometimes feel also that frustrated that I have not answered a single right answer. Okay, so that's the whole idea of making this type of interactions, and also trying to collect so much of information in this 2 hours, 2.5 hours, that would be helpful to you. So please share all your feedbacks, and hopefully I will be again sharing with you the agenda. Next it would be will be decided, we have decided it would be neurosurgery, and then it would be sepsis, antimicrobial, cardiothoracic. We have just shifted little bit towards later part because it's cardiology, so I have included many things from the cardiology section, a cardiac surgery also. So just back to back, if there would be so much of heart related things, then you will be all lost in the heart rather than like the neuro as well as other things would be somehow not given that type of importance. Okay. Thank you very much for your patient listening. Wish you all the best, and hopefully we'll be coming up with another module with this much of efforts as well as information. God bless you all.